Welcome to EHRA Snacks. I'm Rodrigue Garcia from Poitiers in France. We are live from Berlin at EHRA 2024, and I'm very pleased to have two guests today, Nikos Dagres from Berlin and Prashanthan Sanders from Adelaide. We are going to talk about sudden cardiac death and atrial fibrillation. My first question would be to Nikos. Nikos, we now stratify the risk of sudden cardiac death with left ventricular ejection fraction for primary prevention. Could you tell us if there are any other relevant tools that could be useful for risk stratification in this setting?
Yes, this is an important question, and thank you very much. It's exciting being here in Berlin for this fantastic Congress. Sudden cardiac death is a huge challenge, and it remains a huge challenge. We indeed use left ventricular ejection fraction as the main, but actually the only risk stratification criterion, and we know very well that the results are not really satisfactory. So it's far from perfect as a risk stratification tool, and we would really need to have more. But all the research up to now and all the evidence has not really shown any other risk stratification parameter that could be used with sufficient solidity in clinical practice.
Okay, my second question would be, can you tell us more about the PROFIT EHRA trial that is coming soon, or that already started, I think?
That already started, and thank you very much for bringing this up. Well, I'm obviously biased because I'm heavily involved in the trial, but the trial is probably the most important development in that field over the last years, I would say, because a lot of things have changed since all the evidence that is the basis of the guidelines and mainly of the primary prevention ICD implantation. So lots of medications, very effective medications that also target sudden cardiac death. So what we want to do with the PROFIT EHRA trial is to reassess the role of the ICD under contemporary conditions. And indeed it has started. EHRA is heavily involved in the trial, therefore the acronym, which changed from PROFIT to PROFIT EHRA, so that the special role and the special support of the association is really emphasized. We have started, it's a non-inferiority trial reassessing the role of primary prevention ICD implantation in patients who have survived a myocardial infarction. Ambitious, 3,600 patients to be enrolled. It has started some months ago. We are in the phase of recruiting centers, recruiting patients. So it will be an exciting project for the next years, and we're very happy for the support of the ESCNT on that.
We're looking forward to having those results, and it will surely improve patient management.
That is our target.
Let's move to atrial fibrillation, Prash.
Yeah.
Can you tell us a little bit about the evidence with risk factor management in atrial fibrillation?
Thank you for the question, Rodrigue. So what we know is that atrial fibrillation is a progressive disease, and regardless of all the ablation techniques we have, there's a recurrence rate associated with that. And the question is why this is the case. And we know there's a bunch of risk factors that cause progression of the atrial myopathy. And so treating those have now been shown to improve our ability to maintain sinus rhythm, improve the success of ablation procedures. And so we are advocating for a comprehensive management of risk factors in a bid to treat atrial fibrillation.
Okay. You just mentioned atrial fibrillation ablation, and during this Congress, new guidelines have been released. What is new?
So one of the key features of the AF consensus document, ablation consensus document, is a component on modifiable risk factors. And we've introduced an acronym of screening the patients from head to toes for modifiable risk factors in order to improve ablation outcome. This is heart failure being an important component, exercise, arterial hypertension, diabetes, Okay, then we have tobacco, obesity. I'm going to say I missed something on the E. And then we have the last one is sleep apnea. So important factors, and we want people to start using this acronym when they're at the bedside.
Great. Thank you very much, Prash. Thank you to both of you, and we will see you next year in Vienna.